The conference is now being recorded.
Welcome to today's webinar presentation. Ms. Dukevich, we're ready to begin at any time.
Thank you very much, Shannon. I want to welcome everyone today to the Underserved Population Network calls. I'd like to tell you that our calls are 1 to 2 times a month, and we talk about specific topics that are related to underserved populations, such as underserved regions, dually eligible, health disparities, and such as today's topic related to health literacy. We also will be talking about specific topics that are related to small home health agencies, where there is limited resources and barriers for those agencies. And in fact, in November, we're going to have a call that's really focused on small home health agencies. So we want to welcome everyone today to this call. There is a flyer of our upcoming schedule on the UP tab on the homehealthquality.org website. And if we could change the slide. I also wanted to let you know that we just had our second issue of the update. It is a new monthly e-newsletter. It gives you short reviews of current articles or resources that are related to our underserved population. And there's a link for you to read more about that topic. In this current update that just was released the other day, it talks about rural and urban type issues. There are links for resources or other educational activities, as well as our up-network call schedule. If you're not receiving the update and would like to, please contact our hh@wdmi.org website. I also want to let you know that today's call, we do have PowerPoint handouts that are available for you after the call, or you can even download while we're getting ready to start the call. And they're on the UP tab of the HHQI, and that's homehealthquality.org, and go to the UP tab. So we'll go to the next slide. We are also very excited to be kicking off in July Million Hearts Comes to Home Health. Million Hearts is the national initiative by CMS and the CDC in reducing 1 million heart attacks and strokes in 5 years. And home health is now being invited to work in the Million Hearts initiative. Our kickoff webinars are both Tuesday, July the 23rd, or Tuesday, July 30th, from 3 to 4 p.m. Eastern. They will be the identical sessions. You can register now. The registration is open under the webinar tab. For that, we will have national speakers talking about the ABC assets and Million Hearts. So please join us for that as well. Next slide. Our next up networking webinar, we're only doing one a month for the summer month. That will be the 14th of August. It is a webinar, and the registration is open already. It's titled Advancing Health Equity Now, Uniting Our Communities to Bring Healthcare Coverage to All. And Dr. Amada is the assistant professor at Montclair State University, and she's going to be focusing on issues and barriers with the African American population. So this is going to be an extremely interesting webinar. Please note that onto your calendars and register for that session. Next slide. And now let's get down to today's call. I'm very excited to introduce our speaker for today, Jennifer Pierce. She is a health literacy consultant with Center for Integrated Care. Now, a lot of times, because we do a lot of virtual work, I don't normally get to meet the speakers before we have our calls, but I was fortunate a few weeks ago to be at the International Home Care Organization conference, and so was Jennifer. So we got to meet and see some of the work that she is doing and the research work that they are doing at Sutter, and it was a pleasure to meet her. So we're thrilled to have her today on our call. Today she's going to be talking about specific health literacy information related to self-management. Health literacy is a huge problem, basically for every single agency that is on this call today. Health literacy does affect every walk of every type of person that we discover. It can be educated, it can be different races, it can be your neighbor and your family. In addition to today's material that Jennifer's going to be talking about, there are plenty of resources that are available for you and your agency. First, in the Underserved Population Best Practice Package, which is on HHQI, there is an entire section designated on health literacy with many tools and resources that are linked or provided for you right in the package. Also, at the end of this presentation, I'm going to provide you with information about a free 3-part recorded health literacy series by WVMI's Care Transitions Project in West Virginia that is available for you. So a reminder for those that may have just joined us, the PowerPoint handouts from this session are available on the HHQI website under the UT tab, so you can pull those down. The other piece is today, since there are going to be so many people on the call today, we are going to use the chat feature for Q&A. So when you think of a question as Jennifer's presenting, please type it in, and we'll gather those questions and we'll address those at the end. So now let me introduce Jennifer. Jennifer is a writer and editor who specializes in translating complex healthcare concepts into accessible and actionable content. She is definitely a passionate advocate, and you're going to hear that in just a few minutes. For patient engagement through plain language, she consults with providers across the care continuum to implement health care literate care. She currently serves as the health literacy consultant for Sutter Care in Integrated Care, where she has earned Clear Marks Award of Distinction from the Centers for Plain Language in 2012 and 2013. Jennifer also provides consultant services on health literacy. Prior to joining Sutter, Jennifer has led national patient enrollment efforts for the NIH-funded Autoimmune Disease Genetics Research Project at the University of California, San Francisco. She holds a bachelor's degree from the University of California, San Diego, and a master's degree from California State University, East Bay. Jennifer resides near San Francisco with her husband and twin daughters. And so I'm going to turn it over to Jennifer.
Wonderful. Thank you so much, Misty. And I'll start by saying what an honor it is to have the opportunity to talk about health literacy today. It is indeed something I am passionate about, and anytime I have the chance to speak to individuals who are actually out on the front line with patients or in a position where they're making decisions about how care is delivered, I consider it a tremendous honor. So I thank you all for your time. We have a lot of slides to go through today. I'm so grateful that Lucy's made them available on the HHQI website in the form of handouts, because that way you won't have to memorize everything I'm saying. You can simply listen and then reference afterwards, which is actually a health literacy best practice. So you provide the verbal instruction, but you also reinforce with written material. So we're practicing what we preach here today. I wanted to get started by just giving you just a brief overview of how I came to be speaking with you today. I did not intend to pursue a career in the health field. In fact, I have no stomach for health, anything, whether I was born to be a writer and I've always excelled in some plain language communication and was perfectly happy with my given career in public relations and marketing. As luck would have it, during my undergraduate education, I was diagnosed with systemic lupus. And life happens, and you do the best you can with a chronic illness, and you try to continue on with the life you had planned for yourself. And I was doing just that when my rheumatologist in San Francisco suggested I head out to UCSF and do a good research subject and give blood for this autoimmune disease genetic study they were doing, looking for the genes. And so I did. I was sitting there having my blood drawn and looking over their materials and thought, these marketing materials were let's just say they could be improved. And of course I did that for a living, so I volunteered selfishly, feeling like, well, this will increase enrollment and hopefully they'll find a cure for this nasty condition. And I volunteered my time most weekends and they liked the results. And in the meantime, I experienced what it was like to write about something I actually cared about. And as luck would have it, the principal investigator, the rheumatologist heading the study, offered me a job. And that started my medical writing career. That was over 14 years ago. And I quickly came to see the power of plain language. And it was my job to translate this very tricky, technical, genetics research information in form of consent, long 14-page enrollment questionnaires, and translate it in a way that made sense for patients across the country, patients in urban settings and rural settings. And I saw firsthand how a patient who understood what they were being asked to do, how that patient became engaged and became a full participant in the research, even though the patient had nothing to gain. Many of the patients we enrolled would not live to see the results of the research. So it was an incredible experience and a powerful one. And I probably would have been very happy staying at UCSF doing the plain language writing and the national recruitment if it hadn't been for this article, which it changed my life. It was December 5th, 2006, and I was at UCSF. And I, on a day off, went out to my driveway and picked up my Wall Street Journal, and there on the front page, lo and behold, an article about a young woman who would have been my age with lupus. And I was intrigued. My disease on the front page of the Wall Street Journal. And I read, and I realized this woman, Nikki White, had the same set of skills I did at the time. She was college educated. She had some healthcare experience. She volunteered in a hospital trauma ward. She prepared for her medical appointments the same way I did. And she had a support system. She had two parents that were helping her pick through some of the information. But as I continued to read, I saw these barriers that she'd encountered. She had 12 providers, not at all uncommon for those of us with a chronic illness. Depending on each system involved in your illness, you have a specialty or a specialist engaged for that particular organ or body system. So that wasn't surprising. She had Medicaid and then was uninsured. This is she was too ill to work, and so she had to receive Medicaid benefits. There was miscommunication that led to lack of follow-up care. Well, of course, she had 12 providers, and of course they're not all in the same EMR. Very common. And she didn't always understand her options. Well, that's very common, too, because oftentimes doctors don't speak in language that lay people, like myself, can understand. But what horrified me was the fact that she died. And her physician was later quoted by an author who was writing a book, and this was picked up by the New York Times, that she did not die of lupus. She died of the health system. And I realized on this day that the work I was doing in plain language was, in essence, could be a matter of life and death for patients. And the work that needed to be done in terms of making the health system more accessible was something that could literally determine whether a patient with my very condition would make it or not. And I thought, this is bigger. This is bigger than lupus. I need to broaden my education here and learn to speak health system. If I'm going to change the system, I need to learn to speak the system language. So I went back and got a master's degree. I had 5-year-old twins at the time. So obviously this was a passion. It was not easy to go back to graduate school with little children, but it's been well worth it. And now my life is dedicated to reducing system barriers and demand. So that's my main focus. And today I'm here to talk a little bit, putting health literacy into a larger context of patient engagement, which is something everyone in healthcare is interested in now. Identify the skills necessary for shared decision making. This isn't something that one can simply set out and do. It requires skills for both on the patient side and the provider side. Define health literacy and health literate care. What is it exactly? What are we talking about? And then recognize how that affects patients and systems. And then finally, some very practical steps for engaging patients. I'm not a big fan of talking about concepts without actually coming around to say, here's how you start, here's what you can start doing today. So that is a goal, and spend quite a bit of time at the end showing you examples of what you can do and how to get started. So we'll begin at the macro level, patient engagement. And this is the definition, actions individuals must take to obtain the greatest benefit from the healthcare services available to them. And what's interesting about this definition is it's all on the patient. It's determined by the patient actions. And what action the patient takes depends on what skills that patient possesses. So this is where we start to see patient engagement is very, very closely linked to health literacy, also influenced heavily by the skills the patient brings to the table. And this is just a visual definition of patient engagement. It isn't patients and families trying to improve health and health care and then the health professional coming at it from their perspective. Patient engagement really in action, and this is different from the definition I showed you, it really involves this red arrow, patients and families working in concert with health professionals together to improve health and health care, coming at it from the same angle in a mutually agreeable and agreed upon way. And the February issue of Health Affairs, for those 2013, was dedicated to patient engagement. The issue is well worth reading cover to cover, and it one of the articles laid out a continuum of engagement, which I find fascinating because, on the one hand, it's encouraging just about everyone is on the continuum of engagement at the consultation level. And I say this because you see down at the organization design and governance in the red, the box under consultation says organization surveys patients about their care experience. Anyone who sends out a survey to their patient following care, you're engaging your patient that way. But increasingly what we're seeing, and particularly from CMS and on the hospital side, is the hospitals that are involved in the hospital engagement network are expected to be somewhere between the involvement and the partnership and shared leadership level. So the expectation with, as we know, value-based purchasing and several aspects of the Affordable Care Act is that patients and providers are somewhere much further down the continuum of engagement. And one of the things that struck me about this slide was the yellow box at the bottom, the factors influencing engagement. And this yellow box is essentially the foundation upon which engagement is built. And you'll see there, you're looking at the patient, beliefs about the patient role, so the patient's beliefs about their role, health literacy, and education. And at the organizational level, we're talking about policies, practices, and culture. So these pieces here will help determine where you are in this continuum of engagement and how effective you are. And so we'll look more closely. These are the same pieces that were in that yellow box, just put up on the screen so we can see the organizational level, policies, practices, and culture. Patient level, we've got the same. And what I'd like to point out here is from a patient standpoint, a patient like myself can come in with the belief that I am a partner in my care, that my voice matters. I come into my appointments with very high health literacy, and I'm well educated about my condition and about the healthcare system. But if my provider or my provider's organization has policies and practices and culture that don't reflect a high level of patient engagement, I'm hit a stone wall. And I'm about as informed as a patient can get. I do this for a living. So my own experience and what I've also seen in the literature is that the organization really can set the tone. If the health organization has policies and practices that promote health literate care, and by that I mean if the policy is that they don't put out materials that are patient-facing without having those materials viewed by a plain language specialist. If their materials are, if the practice is nothing goes out unless it's in plain language written between maybe 4th and 6th grade level, then that would influence my belief and it would match my health literacy level. If an organization has a culture that sees the provider as the client, I know in hospitals that's been the case in years past, where the doctor is seen as the customer of the hospital. What does that say to the patient? How does that influence the patient's belief about their role? And that tells the patient, you're secondary, you're not our main customer. So if the organization has and is committed to fostering a culture of plain language, a culture of patient engagement, a culture of respect, policies and practices that train providers in plain language communication, those things will feed into and influence the patient, giving them the green light and to speak up. We welcome their input. And if those things are in place, you have the basis for shared decision-making. But shared decision-making requires skills, as I just pointed out. And what we have here are the basic competencies that a patient has to have for shared decision-making. And then on the right, the provider competencies for shared decision-making. So the patient has to bring certain skills to the table. But, as I mentioned before, it's the provider, the organization that sets the tone for eliciting those skills or helping the patient develop those skills. So if the provider is saying, I want to be a partner in care, then the patient has the green light to start defining that preferred relationship. If the provider says, I'm going to present your evidence around your condition and identify your choices in plain language, then the patient actually has the opportunity to evaluate the information because it's accessible to them. And the patient then is invited to negotiate decisions and can begin to articulate their own health issues because they're picking up the language that the provider is using. It's accessible, and therefore the patient feels informed. So there are skills necessary here, and one of the things we can do on the provider side is develop those to begin to define the relationship. And what we do know, and the literature is very rich in this area, that when the patients and providers bring these competencies to the table, we see increases in patient satisfaction, better health outcomes, and better quality of decisions. We're essentially, this is achieving the triple aim. We do know that patient engagement fundamentally relies on health literacy. And we keep coming back to that because ultimately, if a patient isn't understanding what their options are, then they have no chance of being informed. And if they're not informed, we do know that their engagement will suffer and they will not feel empowered to seek out additional information. So let's look at a reality check about where health system demand and complexity and patient skills and abilities are. This is essentially where we are today. We're trying to make some headway, but in this country, patient skills and abilities are far lower than the health system demand and complexity. And in the past, this has been thought of as a patient deficit, that somehow the patients are inadequate. And in reality, in this country, 9 out of 10 adults lack the skills to manage a chronic illness. The shame lies with the healthcare system, because a system that is too complex for the customers to access, if healthcare were a business, you'd be out of business. If you design a product that your customers can't use because it's so complex, no one's going to buy your product. So it's just not, doesn't make sense. So what we're trying to do is achieve by lowering health system demand and complexity, we're trying to achieve health literacy. And this is one of the most advanced definitions of health literacy, in health literacy's evolving short lifespan to new field. Health literacy is seen as a space that exists when patient skills and abilities align with, either are equal to or are above, health system demand and complexity. As soon as health system demand and complexity is one click higher than the patient skills and abilities, you no longer have health literacy. So think of it that way. It's very fluid. So anytime you're dealing with a patient, you need to make sure that that system demand and complexity is aligned with that patient's ability to navigate. Again, I just mentioned this. We have every 10 years a national assessment of adult literacy, and the most recent was 2003, and there was a health literacy component. And what they found is that 20,000 adults aged 16 and over in the United States is very, very large, that 9 out of 10 adults are outside of the proficient realm. So in order to manage effectively a chronic illness, multiple providers, multiple medications, one needs to land in the proficient realm. So only 1 in 10 adults really have the skills to manage a chronic illness. The vast majority are in the intermediate realm. And this next slide shows that same research, that same survey data, but this time is parsed by the highest level of education. And what I also see in EMRs is ask patients at hospital EMRs, this is kind of, what's your highest level of education? And that has appeared in the past to be a proxy for what this patient's health literacy level is. And the reality is, it is not an accurate measure. I draw your attention to the very bottom column that says graduate studies / degree. And we see on the far right that those lines, 33% of individuals with a graduate degree, this is individuals with a master's, a PhD, or a postdoc, only 1/3 of them have sufficient health literacy. So you could literally be talking to a rocket scientist in the hospital bed or in home care, and that individual lacks the skills necessary to manage a chronic illness, because healthcare is it's a world unto itself. And as a layperson working in healthcare, I marvel at the education it takes. You all go to school for years and years to acquire that knowledge and learn that unique language, and the rest of us don't have it. So I caution you to not assume based on a patient's level of education that they then have adequate health literacy, because it's like assuming someone who speaks Spanish is also fluent in French. But no, it's two different things. So we began to look at the same survey data here, this compared by age. And I use this slide to illustrate the fact that health literacy stays rather static up to age 64. We see that the first column is 8% in the proficient realm, and we're at 12% up to age 64. What we do know is that after age 65, health literacy begins to decline, and this is due to the normal aging process, in addition to the fact that the one's interaction with the health system increases as we age. The disease burden increases. So you've essentially got this inverse correlation. As people need more health services as they age, their ability to navigate those services decreases. At age 65, only 3% of those 65 and older are in the proficient realm. And for the home care industry, this is the home care, this is our client base, our patients. The chronically ill, 80% of those 65 and older are chronically ill. And what we see here, looking ahead, by 2015 we'll have 25 million individuals with 3% proficient health literacy. And by 2015, 55 up to 55 million, 3% or less. You can see at 2050, it's a huge number that will be in the 1% proficient health literacy range. So again, the need for healthcare services will skyrocket as our population ages, but individuals' ability to obtain and process and get the most out of those services is really going to be on the decline. So no conversation can occur regarding healthcare quality and cost and just making health more accessible without factoring in health literacy and how that's going to be addressed. And this slide, to me, is probably a picture on the left worth 1,000 words. And in graduate school, we analyzed the ADA, the Americans with Disabilities Act, and it became very clear to me that health literacy could easily be integrated into this act. We would never dream of asking a patient in a wheelchair to attend a medical appointment on the second floor of the building, but that building did not have an elevator. In fact, that building would be shut down. It's against the law. However, we think nothing of handing a patient a consent form written at grade level 14 when the majority of individuals are reading between the average 6th grade level. So there's really no difference here. We do the sheet on the right, we hand that out every day, but we never dream of asking someone with a physical disability on the left to climb a flight of stairs. But they're not different, and that's how we need to begin thinking about health literacy. Quick snapshot of provider competencies. Again, we know that providers need basic competencies to deliver health literate care, and patients need basic competencies. We've got a long way to go on the healthcare provider side. So I see patients coming out of the hospital with heart failure patients with discharge instructions telling them to take their meds BID or PRN. Those words do not make sense. Those acronyms don't make sense without medical training. Prescription labels written in 10-point font or confusing instructions telling the patient to take something, it's a sublingual method of taking medicine. The patients don't know what that means. If I don't know, and I'm ignoring in the coal mine and fairly well educated about these issues, there's no way a patient will understand who hasn't been around the healthcare system. And sometimes written at the grade level 14, like I just showed. Obviously, there's nothing informed about that consent. The reality is up to 80% of patients forget what their doctor said as soon as they leave the doctor's office. I suspect that it may be slightly lower in a home care setting, only because the patient probably is more comfortable at home, but probably not much lower. And this is where it's incredibly important to say, you don't have to memorize everything I'm saying, so you're delivering the instructions orally, but you're also backing up what you've said in plain language and plain, clear written communication. So health literacy very quickly from the quality standpoint. Anyone on the line that's in the hospital system may recognize this part of the CAP survey. During the hospital stay, how often did your nurses explain things in a way you could understand? This is now part of value-based purchasing, so this question now has a dollar sign attached to it. This may be making its way eventually into home care, this type of question. It's now important. The Department of Health and Human Services last fall established a requirement that insurers that must now present their health information or insurance information in nutrition label-like format. So these plain language requirements are hitting hospitals. They're hitting the insurance industry. And I tell home care audiences that it's like if we're standing at the home care train station, the train hasn't pulled in yet, but you can hear the whistle and you can see the smoke in the distance from the train that it's coming. And we need to begin preparing now. The Joint Commission estimates that up to 65% of sentinel events in its database are the result of communication errors, and that some large portion of those have health literacy as a core component, or a failure to account for health literacy. So these are serious, life-threatening events. From the patient standpoint, outcomes are a huge piece, well documented in the literature. We know that patients with low health literacy, keeping in mind that this could be literally a PhD, a highly educated individual, that individual will have worse health outcomes, increased risk of hospitalization, increased mortality rates, that's been shown especially in the heart failure population, and will contribute to cost inflation in this country, and that's because individuals with low health literacy are more likely to skip their medical tests. If a patient doesn't understand why that test is important, and they're looking at their high copay or co-insurance rate, if they don't see the need for it, they're more likely not to get the test done. Oftentimes, with patients with low health literacy are more likely to be seen in the emergency room for non-emergent care, and that certainly bore out in some research. The research Misty we mentioned at the start, we presented at a recent conference. And patients with low health literacy just have a harder time if we see managing chronic diseases. It is work to manage a chronic illness. It takes constant work on a daily basis. You have to check in on a daily basis. And if you understand that work will lead to certain health outcomes, it makes it easier. But again, that understanding has to be there. Blue Cross Blue Shield of California recently surveyed California's poor and near poor. These are individuals on the fringes of the health system. And what they found was intriguing, that patients who feel informed are more likely to ask their doctor questions, ask their provider questions. And most importantly, patients who feel informed about their care and confident about taking a role. Remember, this falls into that patient set of competencies. And my belief is that the provider gives them the green light and is explaining things in their language that feeds that informed and confident side of the patient. That will predict their level of engagement independently and more strongly than all of these factors. And interestingly enough, health literacy is also an independent predictor more strongly of health than all of these factors. So health literacy is sort of the great divide. It doesn't matter how well educated you are, how rich you are, how poor, where you live, what your zip code is. These things are all can all be negated depending on whether or not you are health literate or feel engaged. And we know that if plain information, this is the cycle of engagement, here plain language information is presented, the patient is more likely to feel engaged because they understand the information coming from the provider. And the more engaged the patient feels, the more empowered they are to then request additional information. This is the cycle of patient engagement, again, led by those key competencies. This is how you achieve shared decision-making. And the impetus here, the information at the top, that is where the provider can make a choice. Do I want to present my information clearly and then start this cycle? A wonderful article, again, in that February issue of Health Affairs, takes health literate care and infuses it into the care model, Wagner's formerly chronic care model. And interestingly enough, I am absolutely privileged to be part of a team led by Beth Hennessy and Paula Suter, they developed the integrated care model, the ICM model, and have done training throughout the country on the ICM model. And this takes layers on, and the ICM model is based on the care model. This layers on health literacy on top of it. So it's this multi-layered approach that we are practicing. I equate it to health literacy has always been seen as the cherry on the top of the sundae. It's sort of a nice to have. You still have your sundae, whether there's a cherry on top or not. But this essentially bakes health literacy into the ice cream recipe. So there is no care without health literacy. And the way that you achieve this is by taking the AHRQ, Agency for Healthcare Research and Quality, a Universal Precautions toolkit, all 20 tools, and what it does is it crosses them over with these 6 elements of the care model. And so at each level of the care model, there is a tool, an AHRQ toolkit, to apply, so that you are essentially at every step of the care on the care continuum, you are practicing health literate care. And again, this is that same table I showed at the beginning, patient competencies on the left, provider competencies on the right. But this time we've layered in the health literate care model. And what health literate care does is it aids navigation. It's information about how to make an appointment, how to cancel an appointment, how to find a specialist. If those pieces are presented in plain language, then the patient is able then to navigate the system. If a patient information is presented in language the patient can understand, the patient has some connection to why, for example, having a hot dog for lunch is not a good idea if I have heart failure. If that link between the sodium in the hot dog and heart failure and how those two work together are put there, the patient then has an understanding that would increase adherence. Health literate care gives the patient the vocabulary to discuss their condition. And frankly, every chronic illness has a vocabulary, a unique vocabulary. For heart failure patients need to know the term fluid overload. They need to know shortness of breath. They need to know a variety of other swelling, edema, that type of thing. Lupus is the same way. There's a vocabulary that you need to know to be able to express yourself. And if you learn that vocabulary, that allows you to be able to articulate your health issues and be able to evaluate information and discuss with your doctor. And again, all of this can be started from the provider side, and it leads to reduced costs, improved outcomes, and increased satisfaction. So establishing a baseline, AHRQ put out a consumer assessment of the CAP survey. Hospitals use the HCAP, and home health has its own. There's an item set for health literacy. It's typically measuring from the patient standpoint how health literate is your practice. And unfortunately, it's only out right now. It's been developed for hospitals, not out for measurement. This is the physician practice piece. But I will say I do think it's highly appropriate and could be adapted for use in home care. And these are examples of it. And the reason I'm sharing this page is because oftentimes agencies or hospitals already have a cultural competency committee or some sort of funded initiative to build a cultural competency. And what we see here, the CU questions with the marks in the far right column, those questions are identical to the health literacy questions. The health literacy item set essentially of the first 11 questions would borrow 9 from the cultural competency item set. So the issues of health literate care and culturally competent care are very closely related and can even be seen as two sides of the same coin. This is another way to establish a baseline, and we've used it at Sutter Health and the Heart Failure Continuum of Care program, where we've had patients discharged from the hospital and provided home visits and care. We were screening patients for health literacy on the inpatient side, and we were using the cytosine and adapted tool. And it's essentially a nutrition-based tool. first thing a heart failure patient's going to do when they get home is probably take a shower and then eat something for lunch. And they have to go to their cupboard and decide whether that can of Campbell's soup is a good choice. And if you don't know how to read a nutrition label, how in the world are you supposed to make the right choices to manage your illness? So we were already doing nutrition label teaching. This fit in beautifully. The nurses found that their gut check on whether or not a patient had low or high health literacy was wrong. They were shocked that some patients that they assumed had no health literacy but really had high health literacy, and vice versa. And what was very, very interesting in some recent research that was very preliminary, we found that patients, heart failure patients discharged from 3 Eastern region hospitals, we were surprised. We assumed we'd find a higher readmission rate. What we found was those with a low health literacy score were far more likely to be seen in the emergency department within 30 days. And this was a statistically significant finding. And what was fascinating was these ED visits did not result in an inpatient admission. So these were preventable, in theory. We'll have to do more research, drill down, but these look like preventable ED admissions. So, and what's intriguing is these patients could, in theory, be individuals that would be wonderful candidates for home care and home-based disease management education, because as we know, the length of stay is shrinking. Not all of the education necessary to learn about a new disease can be accomplished in 2 to 3 days, especially if you're sick in a hospital bed. And we also found in the same research that obviously you see here, as soon as you hit 65, individuals with low health literacy are outpacing those with high health literacy. So this is in keeping with what we'd expect to find. So how do you start aligning today? And I know we're getting tight on time, so I'm going to click through these fairly quickly, but this is the resource-rich section of my presentation, and you'll have it. But there is a wonderful document called Attributes of a Health Literate Organization for Apple people using iPhones and Apple products. So there's an app for that, where there's a map for that, and this is the map for getting started in making the organization health literate. A wonderful tool. And the key to it, really, is the universal precaution approach to health literacy. Everyone's familiar with the hand-washing universal precautions. It's the same thing. You don't assume that everyone has high health literacy. What we know from the research is 9 out of 10 adults do not. So we develop all of the materials for maximum accessibility. And this is appropriate for individuals of all reading, education, and socioeconomic levels. And it's been borne out. It is not offensive to individuals with a college degree to get clear information. When was the last time you encountered a patient and you handed them a document or a pamphlet and that patient said, "This is too easy, I want something more complex"? No one does that. With healthcare, you're already stressed and pain, emotionally strained. You want clarity. And this has been borne out again in the test of 2 brochures. Which one is preferred of the patients of our reading and socioeconomic levels? The 6th grade brochure, 6th grade level. And health literate care can start with one document. And this is my mantra. You start off very slowly at your agency or your organization. You assess your materials, and that means getting a few patients, putting the materials in front of those patients and saying, "What do you think? Does this make sense? How do you read this? Can you read it? What are your impressions? What's the key message?" And then based on that feedback, you revise, and then you design principles according to health literacy best practice. And again, all of that is laid out in the Health Literate Toolkit, called EHR2, and that's what you're in. And then test. Bring it back to the patient. Is this better? Is it worse? Did we explain things? Is there something missing? Is there anything offensive? It's a very simple process, very much like the TDSA process, the quality improvement specialists are familiar with. And these are just a couple of before and afters. This is our stoplight form at Sutter when I came, and it did not conform to best practice. In third person, the zones drove navigation. Well, I'm a patient. I'm a person. I don't live in zones. I live in how I feel. That didn't make sense. The graphic doesn't support the text, and the font layout weren't consistent with best practice. This is our revised version, and this was developed, all of our materials are not only developed with content experts, clinical content experts, but they are put before patients. The patients get the final detail, and the patients tell us, this doesn't make sense, well, I use this word. I'm always asking, what's the language the patient would use? And so these documents are developed according to health literacy best practice, but ultimately based on patient input. And this document recently won a Clear Mark Award distinction from the Center for Plain Language, or Stoplight Forms. And we now have Stoplight Forms available in 13 topics. Coming soon, I've got 3 more in development, and we have 5 of these topics developed specifically for hospice. So they're incredibly effective, and they're now being used across the continuum, et cetera, hospital, home care, and ambulatory care, because it's patients aren't silos like the healthcare system. I'm the same person going from hospital to home care to my primary care doctor, and doesn't it make sense that I see the same message across all 3 settings? Very quickly, one of my other topics has been our home care home base med list. I took a look at that and saw immediately there were issues with it in terms of the technical information I didn't understand and issues that were not in compliance with health literacy best practice. So what we've done is we've drafted what we'd like to see, a health literate med list that a patient could possibly then understand and use. And the Tennessee took that up to home care home base, and we are in the process of working with them to develop a health literate medication list. This is an example of our liquid med list used in hospice and also in home care. We've got plain language. This was very confusing to me as a layperson. Morphine, 20 milligrams per milliliter. Exactly what's going on here? So I had a look at the hospice nurse and said, explain it to me. If I was giving it to my dad or a family member, what would I do? And then we took that, and we have a visual piece here at the bottom. We have the table. We have plain language up above, and then the printed on colored paper, which corresponds to the labels on the actual arrest ranges that are left. So, and then finally, this is what's done for a local community hospital who redid their discharge instructions. So patients going home with discharge instructions, 10 pages, and each the pages were divided by discipline. So case management was sending home one page, the surgeon was sending home one page, and the patient doesn't care about the disciplines. All they need to know is what can I eat and drink when I get home. So we redid the electronic discharge instructions with the informatics nurse, and now patients go home with all of their material in plain language, all of their eating and drinking instructions in one section. Of course, it's requiring workflow redesign, but the physicians and the nursing staff are on board, and the allied services are on board with that. And the physicians are thrilled with it, the patients are thrilled with it. And the reality is, if it prevents one readmission, it's paid for itself. So these health literacy projects are cost effective because if they keep patients out of the hospital, that's going to save money. Wonderful free resources online, Medline Plus, out of the library, National Library of Medicine. Excellent material, plain language sheets on medicine, disease states, and then health information translations of information on translations in a variety of languages. This is the AHRQ Universal Precaution Toolkit. Below that is a link to the CAPS item set for health literacy. And then a few interesting reads, some new things for you. And the CDC blog, Bridging the Health Literacy Gap, is something you can subscribe to. I will just say that I'm incredibly impressed with the best practice package Missy's group has put together for the underserved population project. It is very, very comprehensive. So that is another terrific resource to have at your fingertips. And I'll end simply by saying that consumer engagement is standard practice in just about every major industry you can think of. And the question is healthcare any different? Why wouldn't we engage patients? And the answer is yes, it is different because it's a life and death matter. and I'm going to continue to work on this. And I would just want to end by thanking you for your time and saying that if anyone has questions or would like to contact me about additional resources, I invite you to do so. I'm passionate about this and just love hearing from individuals who are out there in the field, and I try to learn every day. I'm a student of health literacy, so I welcome your input. Thank you.
Oh, thank you, Jennifer. That was an excellent presentation. And I hopefully that you got as much out of that presentation as I did in really understanding what it feels like from the patient's perspective and why we have to, as healthcare professionals, bring our material down, educate our patients, and bring them up so that we're operating at that ultimate level that we're going to be able to make an impact for chronic disease management for patients. If you have a question, we do have a little bit of time left. Do go ahead and type that into the chat. And actually, Jennifer, we already have a question from Kathy. Are your materials, such as your heart failure, copyrighted? And can others use your format and illustrations?
Those materials are available. We do have language at the bottom that indicates they're developed by the Sutter Center for Integrated Care. But if you'd like to email me to request use of some of the materials, I'd be more than happy to make those available. And I know that the Sutter Center for Integrated Care is also available to offer some consulting services around implementing the forms. They are part of delivering a health literate care, a larger package there. So absolutely email me, and I'd be more than happy to make a couple of those available.
Wonderful. And we have a question from Cindy related to the zone tools. Do they come in other languages?
As a matter of fact, we are in the process of translating those into 9 different languages. California has, we're unique. Some of the states are in the same boat. We have around 100 languages spoken in California. In our Sutter service area, 9 languages that we are serving, and so they're being translated now. I think we have 6 cell sites translated at this point, so yes.
Great. I'm going to put a little plug in myself. Sutter Healthcare is doing a lot of leading in quality improvement, and Jennifer had also mentioned Beth Hennessy and Paula Suter, and they've been leads in home health, especially in the quality and chronic disease management, and they have been very gracious in sharing lots of tools and resources in many different avenues. So again, thank you, but if you're interested in those items, do contact Jennifer. If you have additional questions, you may contact them as well, or HHQI, and we'll be very happy to make sure that you get in contact with Jennifer. I'm going to go ahead and move to the next slide, and we'll finish up the hour here. Let's see. With the healthcare literacy, we also have that WVMI has a care transitions project. It is 3 one-hour session webinar series. It is recorded, and if you go to your handout, and we will even put a link for that from the archive of this call once we post the archive. So we'll put it there with the handout. By morning, we'll have a link for you. But it is listed, and I did put the full link of where to get to the Care Transitions Project. There are 3 one-hour sessions, and the presenters were from West Virginia University and the West Virginia Geriatric Education Center, Centers for Health Services and Outcome Research at CAMC. It was excellent. I sat through the live sessions. They were wonderful. If you read the underserved population best practice, it really took a lot of that information and went a little further into some more detail. So it really would help you with foundational understanding the different components. Next slide. And this is just a reminder about the next underserved population webinar. Our focus is going to be on the African American population. The registration is open, and I will give you a heads up. Our September topic, we have 2 for September. The first is on diabetic management and working with across settings with some projects. So again, I want to thank you for your time, for attending the Underserved Population Network call, and I want to extremely thank Jennifer for presenting today a wonderful and knowledgeable presentation and passing information on to us.
Thank you, Misty.
And everyone have a wonderful day.